34 so far. Hello, everyone. So I have a couple more in the waiting room. I'm gonna get joined. All right, everyone. Well, it is 1:30, so we will go ahead and get started. So good afternoon, and thanks for joining us today for the fourth session of our long-term care antimicrobial stewardship webinar series. I'm Loretta Fitzgerald with KFMC Health Improvement Partners, and I'm really excited to have the opportunity to learn from Dr. Kelly Wark again. And today's presentation is focused initiatives directed towards diarrheal illnesses and early detection of facility outbreaks. But before we do get started, I do just want to remind you about CNEs. Please remain on for the entirety of the presentation, and please complete that program evaluation form, which will pop up at the end of today's webinar. If for some reason that doesn't pop up for you, just let me know and I can email you the paper form. Let's see here, certificates of attendance and CNE will be sent out via email, and we are recording today's presentation, which will be available on our website soon, usually about 24 hours later. And the recordings from our first 3 sessions, they are on the website along with the handouts, and so we encourage you to share those with your colleagues. But just do note that CNEs are only available for those that attend the live presentation. All right, so for those of you that aren't familiar with Dr. Kelly Wark, she is an assistant professor of infectious disease at the University of Kansas Medical Center, as well as the subject matter expert of antibiotic stewardship. Let's see here, and healthcare associated infections and antimicrobial resistance in KDHE's HAI-AR section. At KDHE, she's the antimicrobial stewardship co-lead, and at KU, she serves on the antibiotic stewardship program and is co-chair of the vaccine and ambulatory subcommittee task force groups. Please welcome Dr. Wark.
Thank you. Do you want to advance them?
Yes.
And I apologize in advance, everyone. I've just noticed in like the past hour, I started to have a little tickle in my throat. So hopefully I'm not coughing because as I talk, my mouth gets drier. So next slide. So today we were going to talk about firstly, really diarrheal illnesses and kind of vomiting in general. So food under the context of foodborne diseases, and then also some on C. diff. But specifically talking about like the diagnostic approaches to this and the infection prevention and control strategies to limit these infections. And at the very end, I'm also going to talk about hepatitis A trends as well, and then just talk a little bit briefly about the vaccine for that, the Havrex. Next slide. So foodborne diseases actually contribute to a pretty significant burden of disease. So just directly related to foodborne infections, it's estimated that in the US, it's about 148 million illnesses per year. So these are people that get sick, have any kind of symptoms. So many more people probably experience that because as we know, some of these infections are transmitted by people that really didn't even identify that they had an infection, but then certainly some people, such as the very young or the very old, do get those infections. So at the minimum, 148 million illnesses. Significant amount of hospitalizations. So actually about 128,000 hospitalizations are related directly to those foodborne infections. But when you talk about it in the broader context of, say, maybe this didn't directly come, maybe this E. coli didn't come directly from a food, or this Campylobacter isn't associated directly to this outbreak. There is even more infections that it causes related to hospitalization. So out of kind of all of those enteric infections, so like cryptosporidium or norovirus, many more hospitalizations occur when you start talking about those. But what is really striking is that, so around 1,300 people die every year in the US from just foodborne diseases, 2,600 from all of those expanded kind of enteric infections. But when you talk about who dies from these infections, it's really a significant amount of people. It's the elderly. So for all those deaths that occur in the US from foodborne illnesses, about half of those actually are in people that are over age 65. Next slide. So many factors contribute to people at older age being at higher risk. So our immune system goes down as we age. Also, they suffer from more chronic diseases. So things like if you're malnourished, you can have a worse kind of more propensity to getting a diarrhea, a gastroenteritis, or diarrhea from infection. If you're immobile, that can also contribute to worsening kind of increased risk. Also, interestingly, our digestive system changes as we get older, and so we also so many people have heartburn, reflux, and so when they take these acid suppressants like protonics or PPI inhibitors or H2 blockers that suppress our acid in our stomach, that actually can make us more at risk of these infections, because our main protection is, our first line of defense is that gastric acid that will kill those pathogens. And so by increasing this use of acid suppressors, probably results in more risk of these infections. But also as we age, our digestive system goes slower. And so if you have a slower digestive system, then you have more time for that bacteria, that virus to actually stay in the bowel, the small bowel, and start to form infections. So, multiple of these kind of components, might contribute to their increased risk of worse outcomes from these types of infections. And also, so some of these infections we'll talk about, they have specifically, I'll bring up some sequelae that can happen after these diarrheal infections. And, but people that are older tend to have more of these sequelae. So after a infection like salmonella or campylobacter, you can get things like Guillain-Barré syndrome, but also it's very common to get things like irritable bowel syndrome or disorder for a period of time after that. So it takes a while for the GI system to return to normal. And also things like reactive arthritis, or what used to be called Reiter's syndrome, where people, if they get some of these like Campylobacter infections, they can have arthritis that really can be quite severe for some time. Next slide. So some of the epidemiology you can see, as we discussed, they're really disproportionately affecting older adults. So this is some graphs from Listeria and Vibrio, and you can see by age, all ages on the teal colored at the bottom. And then when you look to see the incidence per 100,000 population, really you can see that over 80 age group especially is taking out quite a bit of that Listeria, quite a deadly disease for the really young and the really old. And also Vibrio, also you can see the older ages, 70 or really 60 and above, they are more impacted than the entirety of the age of our entirety of our population. Next slide. And then also E. coli 0157H7 also disproportionately affecting older adults, but really the other ones like Campylobacter, Salmonella also. The other one was infections, and then these are hospitalizations. So more likely to be hospitalized is the older adults. Next slide. So, and foodborne related infections contributing to hospitalization really are the highest among the seniors. So when you look at all hospitalizations for adults, gastroenteritis accounted for 1.5% of those. And we'll kind of talk about the differences kind of for some of these pathogens that they cause, if they cause more of an upper or more of like upper meaning vomiting, lower versus diarrhea. And when we talk about those people that are hospitalized, as you saw in kind of some of those graphs, really 75 and above, really starting to get high risk. So when you're 75 and above, they really 7.6 hospitalizations per 100,000. So significantly, like 3 to 4 times fold amount of hospitalizations as those that are at younger ages. So really, this is so important for kind of the population that we're seeing. Next slide. So, and then this is gastro. So when we think about different kinds of months, there's certainly some kinds of infections, like we talk about norovirus, that tends to be more starting in like November and especially like January, kind of into late winter, early spring. But this is a graph of, you can see by month of just gastroenteritis hospitalizations, and there really isn't like a significant time period that is more likely. Really, probably a little bit more in the summer or fall, a little bit higher, but overall it's pretty much year round. Another interesting thing in a lot of this epidemiology literature, really females seem to be a greater risk of hospitalizations. And so whether that's related to, again, their risk factor in some way, is it the acid, are they taking more acid suppressors, is it because they're preparing food, not really sure, but definitely it seems to affect females more than males. Next slide. So the 2030 goals, there were these 4 goals that you can see that were related to foodborne illnesses. So one goal was to reduce salmonella infections. You can see the baseline rate, and this was the 2016 to 18 rate, and it was 15 infections per 100,000 population was kind of the baseline. The target by 2030 was 11 per 100,000. So you can see actually there is some progress towards that 2030 goal. When you look at the other infections that the healthy people set out, the Campylobacter, the Listeria, and the Shiga toxin producing E. coli infections, however, those are not improving. And in fact, a couple of them seems like they're worsening, specifically the Campylobacter and Listeria. It seems like there might be actually going up. It did, and this was based on the most recent 20. You can go on in the next one, Loretta. That was based on the most recent 2021 data, because it did seem like early in the pandemic it did kind of go down, but overall now it's really higher than it was before. So you can see also some additional. This was from the CDC from the 2022 food safety report. So Campylobacter, but you can see some of these other ones like the Cyclospora, which is really more of a protozoan. You can find that in like, sometimes it'll be like berries or berry outbreaks or leaf. That actually has went up 430 percent. So significant increase. And then also you can see Vibrio increases. That one also is associated with like warm water. So there might also be that some component to like maybe change in the temperatures and climates. And then you can see also Yersinia increased 144 fold. So really, either some of them aren't changing, but they're not really see they're improving. And actually, a lot of them seem like they're getting worse. Next slide. So these are norovirus is out of all the just generally, it doesn't have to be a foodborne infection or for foodborne illness, but it is the most common cause of gastroenteritis, and including for foodborne illness, it is the most common also for foodborne illnesses. So generally speaking, if we get a gastroenteritis, there's a good chance it could be norovirus. This is a rate of kind of their graphing over time, the amount of clinic visits, ER visits, hospitalizations that are related to norovirus. And you can see here again, when we talk about our population, our older adults, you can see the rate of the people that are over 85. It's almost double that than the entire adult population. So for people that that have clinic visits or ER visits, that if you're an older person, you're much more likely to you're double likely than the other populations, other ages, to seek an ED, to be in the ED or be hospitalized. So again, just another across the board, pretty much all foodborne illnesses, and also norovirus, because I know last year specifically we were having several outbreaks with norovirus in nursing homes. Next slide. So there is, whereas all foodborne illnesses, there wasn't like a super great seasonal trend. But you can see here, this is for norovirus. Really, it does tend to kind of the same seasonality. Think of it being the same kind of seasonality as RSV. So a lot of it really popping up in the winter. So it's like this is really seems like it starts peaking in January, February, as you can see, and this is over, from 2012 to 2023, these neurosites where they really track it. Next slide. So we talk about these, and there's a big difference in some of the types of, you can get a big clue on the symptoms. So when you talk about gastroenteritis, as the name entails, so it's either of the gastric, so stomach, or the enteritis or small bowel. So when you have infections in that site, it's gonna be predominantly vomiting. So it's your top part of your GI system. So it's the closest to the mouth, and it's the most likely gonna be vomiting. Could have some abdominal pain, could have definitely nausea, sometimes have fevers and chills. This is what, a lot of people refer to as the stomach flu. The flu really wouldn't be like normal influenza, is not likely to cause gastroenteritis. But that's what a lot of people will refer to it as a stomach flu. The number one cause is definitely the norovirus. But following this, you're going to see things like the rotavirus, especially in children, sapovirus, which is kind of like is also kind of a similar to the norovirus and rotavirus group. You can also get one that can cause gastroenteritis is Staph aureus. So in foods, specifically foods like mayonnaise, or you can have that toxin that's formed from Staph aureus, and that toxin is what causes this really severe sudden vomiting after you've ingested that. Also, toxoplasma is more on the gastroenteritis side, so more on the vomiting side. Hepatitis A and Bacillus cereus. All those tend to be a little bit more on the vomiting side. When you get more to the diarrhea side, these you can start thinking maybe a little bit more in the colon. They could still cause some vomiting, but especially if you're talking about like Salmonella, Campylobacter, a lot, especially for E. coli, thinking definitely more on diarrhea. And then C. diff isn't a foodborne illness generally, but again, you're gonna have colitis. You're gonna have the diarrhea. You wouldn't really so much because it's not infecting the stomach or the small bowel. You're probably not gonna have vomiting from that type of infection. Also, we see a lot of cryptosporidium. We'll see, as we mentioned, cyclospora. You can see giardia with some foodborne infections, Yersinia. And all of those are going to be manifested as that nausea, diarrhea, and some abdominal pain. Less commonly, fevers, chills, concurrently with them. Next slide. So where are these coming from? This is from the CDC, the Emerging Infectious Diseases Report or Journal. And so you can see really a lot of these illnesses are coming out of produce. So it used to be, kind of increased over time, where we think of like the leaf, especially the leafy greens. So for instance, the romaine lettuce especially has a lot of associations with outbreaks. Um, Definitely meat and poultry for sure. And then you also can have some from dairy and eggs, you can see on that left hand graph. And then just because the intake's less, definitely less with fish and shellfish. But depending on what kind of pathogen you're talking, both of them, all these kind of bacteria and protozoa, like the E. coli, the Campylobacter, Salmonella, they really still are found a lot in the produce, the leafy greens. We'll occasionally have outbreaks with the berries or the strawberries or things like that. Also, don't forget that we can have stuff like where we had that peanut outbreak a few years ago. So you can definitely have nuts that can be associated with some of these foodborne illnesses too. Next slide. So I find it dramatic. So I would always assume that the chicken that you're handling or pork has it has infection. So there's been a lot of studies with a retail chicken or poultry. And so here's just some of the kind of more recent ones that I was able to find. So the raw chicken, where they would sample this, they found really on average, and this is, they track it across the US, but the retail that they would sample around 12% of those samples of the meat. So the deeper, so they would sample on the skin, and then they would sample more actual meat of that chicken. And so 12% for the meat, but you could think it's like the outside, it's the skin. So probably more likely it's going to be contaminated. So up to 44% of that skin part. And specifically, a lot of like the thighs and legs, it wouldn't be more likely to have it. But really, we're talking like almost half of the chicken that they sampled had salmonella. So presume, and this is in our grocery stores, so presume when you're getting that stuff, cooking it, preparing, you just really should presume that it has salmonella. Even we think of like, this is kind of crazy. I mean, you think of that breaded stuff that's ready to eat chicken. They even sampled that, and actually about a quarter of those, that chicken even had salmonella in it. So, all of it's ground together. So, who knows how many sources of chickens is contributing to these. I mean, thousands, hundreds of thousands and so it's mixed all together. And then that's where it gets contamination. Campylobacter is a little bit less common than salmonella, but you can still see about a third of the retail chickens, when they would sample these in the grocery stores, have Campylobacter. Interestingly, farm chicken, they had lower rates, so maybe it was just the processing, and those rapid, where they go to the industry, and it's just, they can be contaminated over the line. Next slide. This is really something it wasn't on my radar, but I was listening to this book called Big Chicken a couple months ago, and they talked about actually how there was this outbreak in California about two decades ago. They're seeing young female with like this drug resistant E. coli infections, and so actually they were able to trace this back to the poultry in the region that had the same E. coli. And so then subsequently, so I looked into this a little bit more, and it sounds like there's actually quite a bit of literature around these kind of extra intestinal. So there was a pretty big that study where they looked at this California group. About 49% of those E. coli that were resistant to Bactrim, it was the same strain that they found in the poultry in that region. And then they found over time, because they were, with whole genome sequencing, they were able to find that this same E. coli actually spread to and caused infections also in the states of Michigan, Minnesota, and Colorado. And so these people were having pyelonephritis and really bad drug resistant UTIs from this E. coli. And then there was similarly another where they actually studied like a point prevalence study in Arizona, and they looked at chicken and pork, and they found that they actually tracked the retail chicken, and then they looked at the urine samples over a 12-month period. And so they actually found that there was a significant linkage of people that were eating heavier meat to those samples, to their urine samples. And then finally, there was this case. There was many more literature. It was just nowhere on my radar that by eating more of this, these sources, that you could have increased risk of E. coli, UTIs, or other kind of extraintestinal. They actually looked at the intake and say that they found that people that had greater chicken intake was associated with almost a fourfold increased odds of having drug-resistant UTI. And then for pork, it was actually it was a odds ratio of 4. So it was basically 4 for those people that had that with ESBL, E. coli, UTIs. So just other things beyond just the, typical, foodborne illness that we think of, it might be contributing to other things such as the UTIs. Next slide. So getting into the diagnostics, and probably over time where we're starting to diagnose more of these infections, part of it is a lot of this testing that relies on PCRs. So these culture independent diagnostic tests, or you can think of like it, also known as the multiplex PCR test, or sometimes they might be referred to as syndromic panels. So we'll have these GI PCR panels. The first one ever approved was the Luminex, and that was in 2013. But shortly over the next few years, like the BioFire came out in 2014, and then the Verigen in 2014. The first one for the Luminex, and we'll go over in the subsequent slide, but you can see that one contained a significantly less amount of pathogens that it checked. And then that BioFire really was 22 different kind of pathogens. You can see here's kind of there's a good review if you don't want to read it, the journal Clinical Microbiology, where you can see just kind of compares like the sensitivity and specificity and kind of a lot of the stuff like costs and stuff like that. Next slide. So this again, that's that same kind of article, and it talks about kind of a breakdown of the differences in these types of PCRs. And also it gives kind of the differences in the time it takes to process it. So you can see, for instance, for the Verigene, the process time is less than 5 minutes compared to the other, the Luminex, which was 45 minutes. And it was longer to run that Luminex compared to the Verigene or the BioFire. They also gave some kind of prices for the initial, the upfront kind of PCR, and then also they gave some reagent prices. But keep in context, this was $15. So I really don't have a good sense of how it is today. But and I know it, obviously it's different on insurance and et cetera, that how many people are charged, because I've seen people charge as much as $1,000, $1,200 for just getting a PCR panel. So always a consideration. But if you do want any more information, I think this was like a really good article that kind of breaks down the history of it and the differences between these different kind of assays. Next slide. What's happened since those were introduced is that we're relying, so the sensitivity is so high that they can detect viable, non-viable. It just detects, it detects a genetic material, so DNA, RNA. So we don't know if that's, infectious particles. But really our diagnosis has really expanded as a result of those PCR tests. And what also has happened is, where we're starting to rely a lot more on the PCRs, we're actually starting to culture them less frequently. So this was a survey. This is just a couple of the slides, but they checked for, many of the other kinds of things like the cryptosporidium, the salmonella, et cetera. And you can see pretty much across the board, we're relying on PCRs and we're not culturing them as much, which does have impacts on clinical care, because a lot of these infections, like about a third of salmonella is drug resistant. So if we're only relying on the PCR, and we're not culturing it, then we don't know really management wise what is the best treatment to use a lot of times. So just something to kind of also keep in context when we talk about, are we going to start relying on these PCRs, that we still, for management wise, do oftentimes rely on the cultures to kind of tell us what antibiotics are going to be most appropriate to treat these people with. Next slide. So when you, especially for the for the GI panels, the GI PCRs, it's, a huge discussion needs to happen around diagnostic stewardship. So while they lead to MAR diagnosis, a lot of these, they might be detecting multiple pathogens. You might have results of that you don't know what to do with, or by the time the PCR has been ran, they're not really having diarrhea anymore. And so you don't know what to, so they don't really need treatment. So there's a huge discussion around the GI PCR panels. Certainly they're fast. They are very sensitive. You can batch the samples. You could see, as I showed a couple slides ago, they can be done just generally in a few hours for a lot of them. And they're easier than the traditional culture-based test. But what, as I mentioned, they're not providing kind of antibiotic susceptibilities. There's definitely no data on like the strain type. So if you wanted to find out if it was like outbreak related, that's where you get into doing more of the whole genome sequencing. So you're not going to be able to gather that necessarily from those PCRs. And the question of oversensitive. So, are we diagnosing many of these? Because many of these are just supportive treatment in general. They wouldn't require like specific treatment if they're already resolving. So that is certainly something that you need to talk about when you kind of have these discussions about starting to implement a lot of these CIDTs, or culture independent diagnostic tests. Next slide. So yeah, just because it's unable to distinguish kind of from that viable for the non-viable organisms. So for instance, for rotavirus or norovirus, you could be shedding, especially people that his immune system is lower, they can shed these viruses for weeks to months. I've seen even for the norovirus, we're up to 6 months. So what does that mean? What does that mean for infection control. So there's other impacts that needs to be had with these discussions when you start implementing these GI PCR panels. Um, they certainly do increase, the diagnosis, so it's very helpful in that. So some of these are, you're going to catch a lot more pathogens than you would from beef doing from the old kind of culture-based test that we used to rely on a lot more. Subsequently, we're detecting co-pathogens in a lot of samples. Just recently, there was one that one of my partners had Vibrio, and this person wasn't even having diarrhea, and so it's like you get into that situation. What do you treat this or don't treat it because they don't have symptoms? But it was ran. And so you have to so it's a lot of clinical impacts that you definitely need to incorporate in your discussion. And also, I would still be an advocate for running the routine cultures, because I've seen so many more reliance on PCRs only without cultures. And when we're talking about our drug resistant rates for going up for a lot of these infections, it's really difficult to kind of sometimes determine the best treatment for them. Another impact of these is because a lot of the PCRs, they will have C. diff, and so if that PCR panel does not, those PCR panels do not include the two-step testing, where they'll have the toxin antigen. And so you're going to be overdiagnosing a lot of people that might have colonization rather than infection. And we'll talk about that in a subsequent couple slides about the difference for the C. diff, specifically the diagnosis. Next slide. So finally, to talk about kind of just an example of like outbreak response and control, I'm not going to go over like all these different kind of steps, but just I found a really good resource. This is from Pennsylvania. They came up actually with this norovirus and long-term care kind of toolkit, and so this is an example of something that I pulled out of there. Kind of adapted. It kind of just goes through the steps that you would do for when you suspect it, how you're testing, kind of your surveillance every day, the cohorting and the infection control practices that you would do. And kind of the other things like the contact precautions and how long you do that. And so I thought this was an excellent resource. Next slide. And then same thing here. I mean, I think the Pennsylvania, I looked for a lot of different ones. I think the Pennsylvania was honestly the best. But they really go into a lot of checklists and stuff, and kind of what to clean with, and then also address, transfers to hospital or accepting people from hospitals, letting those people know if there is an outbreak going on in the facility, PPE, and then also what to do with staff. Next slide. So the Pennsylvania one, the link is there on the left. And then also I thought this one from University of Washington, it wasn't as descriptive as the Pennsylvania one, but it's about food-borne illnesses in general. And it has so many great resources. So really what it has is links to posters, links to educational handouts, things for staff, line list. There was a line list spreadsheet that was really helpful in that for when you track these. So really, it was just chock full of a really good amount of resources. Is the one for the University of Washington there in the middle. And then the far right one is really more focused on food safety. So it gives a lot of details about like certain kinds of risk of infection. So this type of food, you're at risk of this. This is what you do to prevent this type of, rinsing the lettuce, blah, 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 or cooking the meat at these degrees for this long. So that's really what the FDA one on the far right really is quite detailed in that and helpful. Next slide. So moving on to C. diff. So this was our last threat report from the CDC in 2019. And so it's an urgent, deemed as an urgent threat by the CDC, leading cause of the antibiotic and healthcare associated infectious diarrhea nationally. We seem to have decreasing incidents of healthcare associated C. diff, but subsequently we're actually seeing increases in community associated C. diff. Next slide. So a couple years ago, this was from the New England Journal of Medicine. And you can see the rates on the right, which is the healthcare associated ones. So they do seem to be going down, but the left graph, where you can see over time, the community onset seems like it's increasing a little bit. Next slide. So diagnostic tests. So as I mentioned, when you get into those PCR panels, they do have the C. diff, but what they don't have on those multiplex PCRs is you're not going to detect the antigen. So when you talk about, you've probably heard about this two-step testing for C. diff. What that really incorporates is that it detects for that toxin. So what happens when you're colonized with C. diff is I might have C. diff in my bowel right now, but it's not causing disease. If it starts to cause disease, it starts to release the toxins. So toxins A and B, and really that's how that detects that toxin part of it. So that's kind of the difference. You can detect PCR in kids and people that are having diarrhea. So it's very common, very sensitive. So you're going to detect a lot of it. But if you want to really help with the diagnosis to figure out, is this colonization versus infection, that toxin part is really what helps answer that question. Um, and so it's just really a much more specific test to add on to the PCR. And so, for instance, at KU, where we were having a lot more cases of hospital onset C. diff, we were used to be relying on the PCR alone, adding that two-step testing with a toxin to finding out that indeed a lot of these are probably colonization, don't needing treatment. And so you can kind of change the algorithm of your treatment if it's a two-step: negative toxin, positive PCR, colonization, doesn't need treatment, we'll monitor. Still has impacts on infection and control, obviously. You can go on to the next slide, Loretta. So yeah, basically that's just the kind of really the dilemma about the PCR, is that it is so sensitive. So we were just going to get so many results of C. diff, but differentiating that colonization versus infection is so critical, and knowing who you need to treat. And so if you're relying on the PCR alone, you're probably going to be treating a lot more people than might need to be treated. And so you get exposure to that vancomycin, you get exposure to those antibiotics, for instance, that fidaxomicin, and then that also is associated with, specifically the vancomycin, more associated with increased development of drug-resistant infections, VRE. And you can have people that get a recurrent C. diff diagnosis. And I'll kind of talk about on subsequent slides the limitations of why on kind of repeat testing too. I will say there is no gold standard test for C. diff diagnosis. So really incorporating your kind of clinical assessment and their symptoms is so important to interpret those lab findings. Next slide. So this is the IDSA. So they actually do recommend that we use that toxin stool test with like a multiplex. So you have the PCR and you have the toxin rather than just using the PCR alone. And then some criteria about who you even do test. So have they had diarrhea over 3 or more unformed stools within that 24 hours, off of, laxatives, or, they're like, it wasn't like tube feeds were started and now they have diarrhea, which could be a frequent culprit of having increased stools. Um, Also, we'll see a lot. Sometimes people will repeat testing also for like test of cure, but because these people can have that C. diff, they will be anticipated to have positive testing for quite a while. So if their symptoms have improved or are improving, then really there's not any role for repeat testing. Um, and then definitely not just, not testing asymptomatic patients, because you're going to get a lot of positive results that you won't know what to do with. Next slide. So this is, I think, part of the, I have found it really helpful to talk to patients that have C. diff. And I know this personally because I had C. diff when I was in residency, and I do know it is really horrible and it takes a while for your bowels to get back to normal. But it showed in literature, so this is an observational cohort where they looked at people that were 6 months post C. diff compared to those people that didn't have C. diff. And you can see that basically after the C. diff episode, they had significantly increased risk of having irritable bowel disease or like a functional diarrhea. So in some way, that C. diff really, it doesn't just disrupt our bowel flora, but it disrupts our bowel function. So we tend to have increased loose stools that aren't going to necessarily return to normal, right during treatment or even after treatment. So that's just something I always find really helpful to counsel people, because people, they anticipate, well, I'm being treated. I finished my course, but I'm still having these stools that are not what is my normal or I used to. And so I ask people, well, is it like when you had C. diff and is it increasing? And they're like, well, no, but it's just not back to normal. And I TMI, but know from experience, it takes months, like 6 months to get back to normal. So just also an important part of that, that to know, because what happens is people call back and they say, I'm still having loose stools. Well, is the loose stools has gotten better? Yeah, it is better. Then don't retreat it or retest it. I mean, because you're going to have a lot of these positive tests, because they're still going to show up PCR positive for weeks to potentially, a month. But you can see also in this, people had a lot of irritable bowel syndrome. They have persistent diarrhea, what's called functional diarrhea. So it's a function of the kind of their way that they're having peristalsis in their bowel. They're also having abdominal bloating. So you can see anywhere from 10 to 20%. So very, very common that people have these symptoms after their C. diff. And it's just a matter of the sequelae of that infection. Next slide. And then this was a separate study where it was a case control, long study of almost 900 people. And so really about 14% of those people after their C. diff, they developed in this one, irritable bowel syndrome or heart dyspepsia or heartburn or reflux. And you can see the ratio of developing IBS after C. diff was sixfold. So they're sixfold more likely to develop IBS after their C. diff episode. They're 2 times as likely to develop reflux. So it's really just thinking of these things and helping counsel patients that unfortunately this is what happens after those infections, and it will resolve, but it was going to take some time. Next slide. So these were the updated 2021 guidelines. And so now there actually is a lot. It's kind of was kind of a little bit confusing when they came out with the guidelines, because the upfront recommended treatment, the treatment of choice, is now fidaxomicin. So it moved from either Flagyl or vancomycin to fidaxomicin. And I'll show why that was changed. But there is some controversy, I guess, with this, because fidaxomicin is a very expensive antibiotic. It's a couple $1,000s. And so, there turns logistical problems. So in the hospital, you get admitted for C. diff, you get started on fidaxomicin, you're doing better, you get discharged, and fidaxomicin's not covered. So then you switch to PO vancomycin. And this is like what happens to 3/4 of people, probably. So that's why, I mean, there was a little bit of confusion of why they would recommend this antibiotic, and then that is so expensive, and then insurance hasn't really been as quick to cover it, although it is, it really is our preferred treatment for C. diff. Certainly, PO vancomycin is an alternative, though, and the reason why fidaxomicin was chosen as really a preferred treatment is because it impacts the flora less than the vancomycin does, and definitely less than the Flagyl does. So what happens is by disrupting that normal, like the flora in your GI tract, these people on fidaxomicin tend to have less recurrences. So with treatment for fidaxomicin over vancomycin, you're going to have less people that get recurrent C. diff. And so that's really why they chose fidaxomicin as our frontline treatment. There's also, and you can see there just the days, and there's different ways you can dose it too. Like you can give this kind of, you can extend it from the first 5 days, give it twice a day for the fidaxomicin, then you can give 10 days for once daily. And then you can see there kind of what the recommendations are for the first recurrence or second recurrence. There is this new medicine, or I don't know, a couple years ago, bezlotuximab. It's a monoclonal antibody that actually is towards the toxin. And so this too is an adjunct to treatment. So if someone's, it doesn't treat infection, it doesn't treat the C. diff, but it reduces their recurrences. And when this is administered, you actually, it is recommended that people still be on their C. diff treatment. So if you're treating them with fidaxomicin or vancomycin, they still be on their treatment, and then they get their bezlotaximab towards the end of that treatment. And that bezlotaximab just adds an extra reduction in recurrent C. diff episodes. Bezlotaximab is a little bit difficult, so it's really only going to be administered outpatient. And like the fidaxomicin, it's also very costly. So bezlotaximab really is something that we give for people that are really high, are deemed high risk for having recurrences, and that's going to be, over age 60, people with immune suppression. So even people with liver disease or kidney disease, any of those people will be a candidate for getting the bezlotaximab. Next slide. And so this is kind of why the IDSA and SHEA guidelines chose fidaxomicin, is because you just have sustained C. diff resolution. So just less episodes of recurrences. You can see the relative risk of like 1.5, and this is in comparison to the vancomycin. So we treat with fidaxomicin, but when it's not covered, we move to PO vancomycin. And as an outpatient, surely, what we also do is, it sounds silly, but I don't know what else. There's not like any great solution at this point, but sometimes we'll just send both the fidaxomicin and the PO vancomycin and let the pharmacy know the preferred treatment's fidaxomicin. But if it's not covered, then fill the PO vancomycin. Next slide. Yeah, there is this, I'll go over this. There's this, the patient assistance program, PAP. And this is a way that Merck has, kind of has this program that you can apply to this. And it actually is pretty quick. I went onto the website and filled it out. And they will then provide the fidaxomicin for basically free. Next slide. This, I think on the next slide, yeah, is where I gave the links for the Merck. This is for the PAP. There's an enrollment form, and you can kind of just, they actually also expedite the shipping. So basically the person should get the antibiotic the next day. So it's not like you got approved for for the fidaxomicin on their patient assistant and they don't get it for, 5 days. They expedite it, so they should be given it the next one. And then I do have KFMC asked for everyone is fidaxomicin being covered by Medicare. And I don't know that if people have to weigh in for that. I'm trying to think of my patients on Medicare, if it's been consistently covering it. I don't feel like it's consistently covered it on Medicare. Next slide. So C. diff outbreak and response. So I'm going to give you some resources also. So these are just kind of the control interventions, pretty similar in general for the norovirus. But this just kind of goes into kind of like checklists for kind of how long you would keep them in contact, and then really emphasizing the hand hygiene. That's really cornerstone to all these outbreaks, is hand hygiene. Next slide. And then also an extra component is antibiotic stewardship, because that by putting them on an antibiotic is really the major risk factors for disrupting that that GI flora, so that it allows the C. diff to kind of take over. Next slide. So this is an old study that looked at the efficacy of hand hygiene methods for removing the C. diff spores from the hands. So you can see the green, which is the warm water and soap, and the cold water and soap, which is kind of that light yellow color, are the most effective. And then and subsequently, that really is why the soap and water is recommended. You can see the HR, the alcohol hand rub, on the red is not it does not decrease. The colony counts are really not reduced compared to the soap and water. And that's really dislodging kind of those spores from that is really why that's so effective. Next slide. So these are the resources. So these are some great, these are from Minnesota. I looked around again for some kind of long-term care and C. diff. And these were some great algorithms, I thought, from Minnesota, and early recognition and the testing algorithm, and then the contact precautions algorithm. And then also if there's like a facility, a lot of facility cases or an outbreak going on, the room placement kind of algorithm. Next slide. And then this is also from the same, they have like a toolkit for C. diff basically. And this was a policy, like a adaptable, downloadable policy Word document. And then also on the right is Rob Geist created the surveillance spreadsheet, interactive spreadsheet. And so one of these, you can see here, this is a kind of control chart for C. diff. So where your facility can just track it. You can also track other things like catheter days, CODIs, UTIs. So it's a really, and then that's the link for the download of the Excel spreadsheet. So a very helpful kind of resource that Rob created. Next slide. So finally, in the last 10 minutes, going to talk about hepatitis A outbreaks. Next slide. So a couple years ago, we started to see a lot more cases of C. diff, or C. diff, hepatitis A. And so I was kind of surprised when I always pull up this map to see really how many cases were occurring in Kansas and specifically Missouri. You can see there was over 1,100 cases from I think it was 21 to 23. And actually, if you click on that link for the CDC website, you can see that actually out of Missouri, 58% of those people that got hepatitis A were hospitalized with 5 deaths. And then in Kansas, 78% of those people that got those hepatitis A cases were hospitalized and 5 deaths. It actually was declared over in Kansas and Missouri. I actually do think, I have to double check actually. I think it almost is over because the cases have decreased, but I can't remember for sure if it was declared over in Missouri. Next slide. So this is the national, you can kind of see over time. So this is nationally our hepatitis A rates. And you can see how it kind of peaked in 1971, where there was a rate of about 29 infections per 100,000 populations, which really headed into a NADAR in 2010 or 2011 with only 0.4 cases per 100,000. So dramatic decrease. The vaccine was introduced in 1998. And at that point, when it was introduced, it was around 11 cases, or 11, 12 cases per 100,000. Next slide. But what you'll see from 2010, more recently in this past few years, we've been seeing more cases of hepatitis A. Really from 2016, 2017 onwards, 2018, it popped back up to a rate of 6 per 100,000. And you can see here, really what drove a lot of those down is certainly infection control, but the hepatitis A vaccine, which is Havrix, when that was introduced. And so this is a very, very effective vaccine for preventing hepatitis A. And so Havrix is the hepatitis, and I'll go over this a subsequent slide. Hepatitis A vaccine is Havrix, and then you can get a combo vaccine that's hepatitis A plus B called Twinrix. And so what you can see here for people that are vaccinated against hepatitis A, pretty good in kids. So kids or adolescents, age 13 to 17, about 70% are vaccinated. And then the whole 19 to 35, 60%. But when you start getting into the I think there might be a I think I put that age there. It's really supposed to be kids actually, not 35-year-olds, because when you get adults over age 19 that have been hepatitis A vaccinated, it's only 11%. And then people over age 50, it's 6%. So really kids certainly, like daycare centers. There's been a lot of efforts to get them vaccinated. But a lot of these people that are getting hospitalized is our older people that then, go into liver failure, and then that's how they die from hepatitis A. So as you can see, they're really, really low rates of vaccination. Next slide. So you can see here, generally the cases of, these are the cases of in Kansas from 2006 to 2020. Next slide. And then when we adapt that to kind of the incidence rates, we're still below our national rate. So we're definitely still lower in Kansas. They're definitely a lot higher in Missouri. But I think we still have room to go, since, there is still deaths associated with this, hospitalizations associated with this, and outbreaks continue. Next slide. So as I mentioned, the double one, the Hep A plus B, is Twinrix, and then just hepatitis vaccine A alone is the one that's called Havrix. Once you get the hepatitis A, you're considered to have lifelong immunity after that. You give 2 doses of the Havrix, so at day 0, and then 6 to 12 months later is when you get that second dose. Next slide. So this was just kind of on the left side, talking about how really there's a high persistence of antibodies after the hepatitis A vaccine, so it lasts a long time. It's not thought that you have to recheck like the antibodies to see if someone's immune. Generally speaking, if they got the hepatitis A vaccine, they're considered immune. If someone doesn't know, or I don't know if I got vaccinated, or you as a provider don't know if the patient got vaccinated, what you do is you check the hepatitis A antibody. And what you really want is the IgG, because so that's the indicator of whether you can't differentiate if they had a vaccine or natural infection. But if they're IgG positive for Hep A, then they're immune. They don't need a vaccine. So that is something to consider, because a lot of times what's on this acute hepatitis panel, it's only the IgM. So that detects acute infection. It doesn't give you any idea of whether they've been vaccinated or immune. Our highest risk is really, people that, of course, people with liver disease, cirrhosis, homeless people, very high risk, drug use, HIV, people, men who have sex with men, healthcare workers, or people that work with these high risk populations, or of course, if you're traveling to an area where there's a lot of hepatitis A uh, incidents. Next slide. So, just some strategies in general to vaccinate, not just for Hep A, but really all, any kind of vaccine. This is kind of different, broke down by facility, provider, um, occupational health, cooperation, but really these standing orders. So, on admission or on discharge, this is a standing order. They get the vaccine. That really increases the uptake. Certainly, you can use your EHR. You can use an algorithm to identify those most high-risk patients, based on, their underlying, if they have liver disease or if they have kidney disease, making sure that they really do get vaccinated. Also, another thing, just in general, getting our leadership to support this. And for instance, taking a picture of them getting vaccinated, making that visual to the whole institution, the whole facility. So you're just changing the culture. You're encouraging, setting that example. Also, provider-based strategies, such as checklist. There was this meta-analysis where they looked at 41 studies and actually giving those reminders. So a lot of times these messages do pop up reminders, but it increases those vaccination rate by 80%. So that's why there's so much of those reminders, because they really do work. The IDSA actually issued an executive summary, citing that, this really be part of the quality of care metric to incorporate, and you could incorporate kind of whatever vaccine you chose to kind of track, and partnering with our occupational health, to make sure that we're, having flexible ability to vaccinate people, the clinic time, or the time of day, free access, or, without the out of pocket, to healthcare workers. Next slide. Any questions?
Not seeing any in the chat. Feel free to take yourself off mute if you would like, or you can place a question in the chat.
Yeah, you have a hand up.
Oh, I don't see that. Can you see who that is?
Yeah.
Oh, that's me. Hi, Dr. Work.
Hey.
That was a lot of information. Thank you. But one thing, I think it's because we don't do that. I was just interested. STEC, I know you avoid giving antibiotics, but the others like Salmonella and others, like what's the sort of like approach to treatment when you would, when you wouldn't, and sort of,
Yeah. So most of those really, for Salmonella, you would treat, Campylobacter, you would treat. A lot of the ones where I was saying that they improve with supportive care, so those definitely are more so like Cryptosporidium, Giardia, a lot of those resolve without treatment. But as for like the bacteria wise, those would generally be treated. If you have traveler's diarrhea, so someone's returned and they have diarrhea, that's something where you supportive care. But if they're not improving, and then that's where you can kind of go to antibiotics. I don't know if that answers your question very good.
Yeah, that very much does. So with STEC, is that also like is it cut and dry where you don't give antibiotics, or is that also something where you might give antibiotics at times?
No, it is. I would fit that into the traveler's diarrhea category. So yeah, if they're improving, that one would not. So that's the general recommendation. If your population that you're talking about is high risk, older, elderly, immunocompromised, then that would be an indication to treat. Mm-hmm.
Thank you.
And I will say, like, for instance, Salmonella, like we would always treat that, because what happens is that can get into your bloodstream. So about 10% of those cases can get a bacteremia. And then I've seen people where it sets up shop on their heart vessels and they get like aortic infections, aortitis. I had someone that had vessels in their brain that had Salmonella, and then it requires like prolonged antibiotics. So that's one thing about some of those, like Salmonella in particular. Yeah, we would always treat that.
Thank you.
Any other questions? Hey.
Kelly, I do have, Kelly, I know you didn't talk about fecal transplant, but that's still something that is an option for those people who have prolonged C. diff, correct?
Yeah. So that was, I didn't really talk about that, but in the guidelines, if you have recurrences, actually, I think it's the second episode. So you had C. diff, you got a recurrences, and now you're on your third, I guess, episode. They make it kind of confusing. They say second recurrence or third, but it's third episode. Then that is an indication for fecal transplant. It was on hold for a while because there was some drug resistant infections that were transmitted by the fecal transplants. So people, I don't know, one or two people actually died from a drug resistant infection. And so it was put on hold. But yes, now it has been, they changed the way where the donor screen and the screening process. So now that is back to being an option, is fecal transplant.
Okay. And not just everybody does that, correct?
We honestly, I mean, I think it's very effective, very, very effective, but we don't do it as much anymore. Really, when you get into treating with fidaxomicin, and then if you use that adjunct, that bezlotuximab, you're really reducing those recurrences. So, and we can offer people like, hey, you could do the fecal transplant, or we can try this fidaxomicin plus the bezlotuximab. Most people would rather do that combo than go and do the fecal transplant. Yeah, so I would say I don't have the top of my head off of the literature, like of the recurrences for that combo of the bezlotuximab, that monoclonal, versus the fecal transplant, but they're really pretty high. They really do reduce recurrences.
Okay, thank you.
And that bezlotuximab is an infusion. That's why it's done. So it's not done outpatient. And so if you're in the hospital, they can't get it then. So once we set it up, and they have to be like recovering, we don't give it up front. They're improving. They're discharged, and then if they go back to home, or they're at a they're in a nursing home or whatever, then at that point, that's when they get the bezlotuximab.
All right. If there aren't any other questions, we'll go ahead and wrap things up. So thank you for another great presentation, and also thanks to everyone for joining us today. Upon ending the webinar, as long as you don't hit the X to close the window, the survey should appear. So please take a couple minutes to fill that out. And hopefully you can join us next month. Our next and last session is October 19th at 1:30, and it is focused stewardship initiatives directed towards shorter courses. So thank you again, everyone, and have a great rest of your day.